in Neuro-Oncology and Drug Development at the Royal Marsden Hospital Institute of Cancer Research. In 2018, she was awarded an inaugural Aspire Clinical Fellowship in Adolescent and Young Adult Medical, Adolescent and Young Adult Oncology. She is a member of the NCCP Children's AYA Clinical Leads Group, developing Ireland's national AYA cancer network, and sits on the executive committee of Trinity St. James's Cancer Institute. Her research interests include the disparities in care experienced by AYAs with cancer, transition in AYA cancer, and the role of exercise in this patient population. She's a founding member of AYA Cancer Ireland, a special interest group for healthcare professionals in Ireland, and is proud to partner with young people with cancer to drive cancer research in Ireland. So this meeting will be recorded. Please everybody mute, and we will take questions at the end. Thank you.
Thanks, Owen. I'm going to go ahead and share my screen. And please let me know if you can't see the slides. So good afternoon, everyone. As Owen mentioned, I'm Sherelle. I am a medical oncologist with a background of adult medical oncology, but I now work across Children's Health Ireland at Crumlin and Trinity St. James's Cancer Institute. I'm going to talk a little bit about developments in AYA cancer care, a little bit about what exactly I mean when I say AYA cancer, then AYA cancer in Ireland, or AYA cancer future, and then very briefly, if we have time, I'll touch on global perspectives on AYA cancer. So when we talk about an AYA, what do we mean and who are the AYAs attending cancer services? And I'm going to come back to the definition of an AYA in a second. But I guess the group that we're talking about primarily when we're talking about the development of Ireland's AYA cancer services are those newly diagnosed young people. But there are two other groups that are in who will transition through kind of the AYA age range, and they are the childhood cancer survivors, and then those patients who are diagnosed in early adolescence, so kind of 12, 13 and up. But what age does AYA mean, and why is it a problem? So AYA cancer, really, these patients are in no man's land. It's very much a unique disease constellation because epidemiologically they're different, clinically they have different diseases, and biologically they're different both as a cancer type, but also as the young person is progressing through puberty and adolescence. And then all of that leads to a very unique psychosocial and developmental challenge that isn't necessarily catered for by either the pediatric or the adult sphere. The age range for AYA cancer varies depending upon which hospital you're in and which continent you're in particular. So if you are in North America, for example, AYA will go from 13 up to 39, and there are certain days where I believe that should definitely exist up to 39 when I'm feeling particularly young myself. Ireland, we are using the age range of 16 to 24, but we do extend that down to 13 here at CHI in Crumlin. And you can see this broadly maps to a lot of our colleagues in Europe and in particular to the UK who really have led the development of AYA cancer services. It's important because AYA cancer is the leading cause of disease-related death in this age range. So we know that one of the biggest reasons for death in this age range are kind of the accidental suicide, homicides, undetermined deaths. But if we're looking at a disease subtype, cancer is the biggest single disease. And so really, it has an potential to impact for a very long period of time. And it's often the very first time these young people will interact with the healthcare environment. And so it's a very important first interaction for them. Their epidemiology is very different. So if we look across Europe, there are 150,000 cases between the ages of 18 and 39. The disease subtypes are different. So if we think about the disease subtypes in the older adult population, they're primarily epithelial cancers. So cancers that occur as a result of repetitive carcinogenic hits throughout one's lifetime. In the AYA subgroup, it's more likely to be diseases like leukemia and lymphoma, but also CNS tumors. So that's brain and spinal cord tumors of varying grades. So that can be ranging from a very low grade tumor that will require lifelong follow-up to something that's aggressive like a diffuse midline glioma or a glioblastoma multiforme, which is invariably fatal. But we also see an emergence of the epithelial cancers, the kind of adult cancers that we think of, melanoma, colorectal, breast, and thyroid cancer. We know that survival varies depending upon the disease extent and the biological features, but actually that overall we're doing pretty well from a survival perspective. And I'll return to this in the future because it's actually becomes very important. And we know that their biological variants are very different. So we know that the subtypes, say, for example, of melanoma in AYA cancer, actually tend to have a better prognosis than those that occur in older adults. Whereas if we look at, for example, a disease like ALL, which Owen will be much better to speak in depth about, but we know that the subtype of ALL that occurs in the AYA population is more likely to have poorer prognostic markers than compared to the pediatric population, for example. And again, this is just a really nice graph from a recent ESMO publication, but you can see really that between the ages of 15 and 24, there are primarily kind of what we consider primitive or leukemias, lymphomas, CNS and blood tumors, but actually there then begins to develop an increase in the carcinomas as these patients get older. This slide though really is where the need for AYA-specific services arises from. So this is now an old paper from Archie Blair, who's considered to be the kind of godfather, grandfather of AYA cancer services. And it looked at the improvements in 5-year survival that have been achieved for all age ranges over the last couple of decades. And what you can see here is that really we've done a great job in improving the survival in the elderly population. And we've done a reasonably good job of improving the survival of the pediatric population. So this is the average annual percentage change. So year on year, we've gained just over 2%, say if you're between the ages of 70 and 75 in your overall in your 5-year survival. Whereas if you're within the age range, and specifically within the North American age range, that actually you've had a very static change in your overall survival. And in fact, in some instances, you've had a decrease. And I'll return to why that might be. We know that the diagnosis in an AYA patient can often be delayed, and that's because young people can consider themselves to be unaffected by cancer. The cancer doesn't happen to a young person. We know that we as healthcare professionals can often, not think of a cancer diagnosis. And if you think about it, lymphoma and CNS tumors are very common diseases in these patients, but a headache or weight loss, night sweats, fatigue can all be pretty non-specific unless they're happening kind of in someone with a heightened level of suspicion. And I think what's important to know is that what often changes for these young people is not so much, it's not that they have a red flag symptom, but actually their pattern of healthcare use changes in the preceding year prior to the diagnosis. We know that demanding education and workplace obligations can lead an AYA to neglect their health issues. And in other countries, issues such as insurance can be a major issue. In Ireland, we don't fully understand our pathways to treatment. So if anyone out there is looking for an interesting project, please come and talk to me. At present, we would say 3 out of 4 AYA cancer survivors achieve long-term survival, but actually the most recent data from Ireland would say that actually 90% of our patients are surviving over 5 years. The downside to that is the cure and treating patients with a curative aim means that we have to give most treatments in a state-of-the-art fashion, which means primarily we're using combined modality treatment with aggressive surgery, sometimes high-dose radiotherapy. And I know at least one, I know Dr. Lyons and Dr. Rock are both on, and they can speak better than I can about radiotherapy, but that's an importance from a long-term complication perspective. What's most different, I would say, between the pediatric and the adult approach is an absolute adherence to the chemotherapy schedule and avoiding any unnecessary treatment delays or dose reductions. But most of all, participation in clinical trials is key for all these patients. What's important to note is that many international bodies, including the National Institute for Health and Clinical Excellence in the UK, or NICE, and the US National Cancer Institute have both recommended that AYAs with cancer should be treated in a dedicated, centralized fashion. We know that they need skilled personnel and they need appropriate infrastructure, both kind of physical infrastructure, but also personnel infrastructure. We know their outcomes are superior when they're given in a reference cancer centre, so when their care is centralised and when they have access to clinical trials. And, if we think about our surgical outcomes, where we know that the number of operative interventions and the number of a certain type of procedure you're doing improves your outcomes, that would seem to be the same case in AYAs with cancer. A very different piece to an adolescent young adult assessment is a thing called a HEADS assessment, which has been on the go now for 20 years and is really a strengths-based approach to treatment. It tackles these various pillars of a young person's lives. People sometimes worry, how am I going to possibly get through all of these things in one sitting? The answer is you're not, certainly not the first time or the second time you use it, but it's a tool to develop a conversation and a relationship with a young person so that they then know that you're a person of trust and that you can kind of maintain confidentiality. But it's important, the parents shouldn't be in the room for these conversations. And that's a little bit of learning on our behalf on how do you ask a parent to leave and how do you negotiate those discussions. If I switch focus now to Ireland and Ireland's AYA Cancer Service Network, we are as yet unbranded, so that's why we're in a very subdued logo. Ireland's AYA Cancer Services.
Yeah, I'm just going out for a walk and I'll be back. Yeah, 2 o'clock. Yeah, thanks a lot. Thanks.
Arisen as a result of the most recent cancer strategy in 2017, which was the first to identify AYAs as a specific need population. And that led to the development and the publication in 2021 for the framework that we're basing all of our work on. And that has involved developing a network. Ultimately, what we're looking for is accessible, equitable, and developmentally appropriate care. And the reason we say age, we don't say age appropriate and we say developmentally appropriate, is a recognition that age is a single identifier, whereas someone's developmental stage is a multitude of factors. And we want this for all AYAs who are diagnosed with cancer across the spectrum of care so that they get better outcomes and better quality of life. And we do this through MDT and partnerships. So we have a national MDM, which is based on a hub and spoke model, accessible to anyone in any hospital around the country. And we've had many patients from Cork, from all of the sites in Cork, discuss thereat. We have a National Young Persons Advisory Group, which is a collection of young people who have had or are having treatment for cancer, supported by a number of charitable institutions, including the Irish Cancer Society. And that allows us to discuss both research but also clinical programs. Our aim is that our healthcare professionals are integrated within the current structure rather than trying to develop something new. We want to prioritise and ensure we have adequate staffing. We want to increase access to clinical trials, and we want to advance the understanding from a genomic and molecular biology perspective. To do all this, we need data. And so part of our plan over the next year is to develop a national prospective database of all AYA cancer patients in Ireland. So what's really important is that this is all very young person centred. So young people should have the opportunity to share their opinions and that they're involved in the design and delivery of research and services, which is why YPAG has become such a key component of our service development. In Ireland, we have between the paediatric and the up to AYA, we have almost 400 new patients diagnosed every year. And if you think about how dedicated an appointment we have, kind of service we have set up for the 0 to 15, who are all centralised and treated within Crumlin, those AYA patients really are scattered to the wind. And it wouldn't be unusual for a single cancer centre to see maybe 1 or 2 over the course of the year. And that means then that young person probably never sees another young person like them in clinic. So what we've done is we've developed a national network where CHI is currently treating patients up to the age of 16, but with the plan that when we move to the new National Children's Hospital at the future date, wherever that may be, that we would expand the age range up to 20. We'll then also, there are 3 adult hospitals which are part of the AYA Cancer Services Network. There's Cork University Hospital, University Hospital Galway, and St James's Hospital. And each of these have had some dedicated funding for CAS, or clinical nurse specialists, for data management, again, identifying the fact that actually data is going to be key to driving this forward. And then also for clinical lead, and Owen, we're very grateful, has taken on that mantle in CUH. The ideal pathway is that we would expedite the diagnostic pathway for a young person presenting with a likely malignancy, acknowledging the fact that, unlike older patients, there are very few things that, for example, causes a mass in the mediastinum of a 17-year-old if they've got an AFP of 10,000. The idea is that within all of this, patients both have their site-specific disease discussion, but also would have their national MDM discussion. And within all that, it's continuing between the survivorship, recurrence, and referral back to within the team and without the team. Our MDM happens once a week. It happens either on a Tuesday or a Wednesday, depending upon the week. So Tuesdays at 1, Wednesdays at 8 a.m. We'll discuss any young person who's been diagnosed with cancer to ensure that they have access to all of the psychosocial supports. And then we've also had a number of discussions where there's a crosstalk and where we need both the pediatric and the adult input from a treatment decision perspective. In terms of who attends, there are lots of us who attend, including our medical specialists, nursing specialists, AHPs, and our AYA professionals, but we would encourage and welcome anyone who is interested in the area to join, even to listen and observe for the first few, and then maybe get brave and speak up. The next steps, I discussed age-appropriate environments. So the ideal and the long-term goal is that young people need a dedicated unit where they're treated like adults in terms of having open and honest discussions, but have the privileges and the time that children get. And that is the big difference between pediatric and adult oncology at present, is that the time that I have to spend with an adult patient in clinic in St. James's versus the time that I would have to spend with a pediatric patient is very, very different. They need to see their peers. They need their partners, their parents to stay with them. They need somewhere to go that's not bed. So if we think about, for example, those patients who have long-term admissions, such as those having transplants, bone marrow transplants, they are in hospital for a very long period of time and often confined to their room. They need something to sit in that's not a bed. The other key piece is fertility preservation. So fertility preservation or lack thereof is a repeated source of regret for young people who have not managed to preserve prior to treatment. At present, our services in Ireland are relatively restrictive when we compare them to what's available internationally, where we can do either oocyte or embryo cryopreservation for young women and sperm cryopreservation for young men. But for those patients who are either too sick, too young, or incapable of providing a sperm sample, we don't currently have testis tissue cryopreservation or electro or auto ejaculation. Now, both of those services are in progress, and I anticipate that there will be changes on that over the next year. Testis tissue cryopreservation remains, in theory, a research avenue, although it is anticipated that's going to change in the next 6 months also. Ovarian tissue cryopreservation is much more established internationally, but again, our challenges in Ireland have primarily related to storage of the ovarian tissue. And so we've had a number of patients who've travelled over to the UK, to Sheila Lane in Oxford. And again, it's something that we're working on developing and having an in-country solution to. I mentioned clinical trials. So we know that clinical trials and enrollment in clinical trials is vital for all cancer patients, not just AYA cancer patients, but for every single cancer patient. We know that for AYAs who are treated on trial, and this is old data, back from 2017, but nonetheless, I think underlines the importance of it, that there's an approximately 20% difference in survival and the mortality risks halves. And I think if we had any drug that offered this, we would be giving it to every patient. The challenge of not having AYAs on clinical trials is not just that they're not getting access to early drugs, it also means they're not having access to the correlative studies that are occurring within the clinical trial framework. Some of the challenges are around the age range. So that 16 to 18 piece is hugely important, but the regulators are actually moving to remove that. So the FDA now in the US would advocate a lower age limit of 12 for those trials of relevant drugs. So not necessarily suggesting that if you're having a study in prostate cancer, for example, you need to be able to open it and enroll AYA cancer patients in it. But if you're having something in a cervical cancer, for example, then actually you should consider those. The MHRA in the UK would also advocate for it because they believe that those patients should have access to trials as well. The ethics around it are very difficult because a 16-year-old in Ireland can consent to participate in an interventional trial. They can, in theory, consent to having a bone marrow transplant, but they cannot consent to the transfer of their data, which is a weird anomaly with GDPR that no one really isn't 100% sure why that happened. So you need parental or guardian consent, which is not a problem, but where you are not necessarily comfortable with it, people aren't used to doing it. And locally, the challenges are, so if I have a patient, say, for example, I have most recently a 23-year-old who's got a recurrent pediatric tumor, and realistically, I'd like to treat them in a trial that's open in Crumlin, I can't. And similarly, if I've got a 15-year-old who I'd like to treat in a trial that's open in James's, I can't. So how do we work across that site? Skip past this, but the Altogether trial is potentially an avenue and a framework for this. And I know both Owen and Mary Cahill have been very heavily involved in its implementation and rolling out in Ireland. And hopefully we'll start having their first patients enrolled in it in the next couple of weeks. So it's a trial in ALL, which is the commonest childhood malignancy. It has an expanded age cohort up to 45, although in Ireland we're going to 24. And in Ireland, we're leading the biobank component. But it is a potential framework on which we can take further cross ages, AYA specific or AYA non-specific trials across the country. And then briefly, if I speak on global perspectives, and I know I'm running out of time very quickly. So late toxicities are a huge problem for the AYA cancer cohort. I mentioned that we have a 90% overall survival, and obviously what we're keen is that this survival is maximized. We know that these effects can be caused by the cancer, but also by the delivery of the intensive multimodality curative treatment and impact every aspect of the patient's health, their quality of life, and their psychological well-being, and present a real barrier to the young person returning to education and work and living their best life. We can see that all-cause and cause-specific mortality among 5-year survivors of childhood cancer does increase, although has decreased over the preceding decades. So the 1970s, most toxic, 1980s, least toxic, and we would hope that in the coming years we'll see a decrease in the overall toxicities as we now are increasingly aware and adapting and tailoring our treatment with an eye to minimizing toxicity and maximizing survival. And again, this looks at chronic health conditions. So we know that a childhood or an AYA cancer survivor is much more likely to have a chronic health condition and to have a number of them compared with their age-matched cohort. And I'll finally finish by the most recent AYA Global Congress happened in June of 2023, with a key discussion around equity, equality, inclusion, and diversity. That's equity and equality between patients within a country, but also thinking about the global south and how we can appropriately advocate for their access to care. But I was really struck by this poster, which challenged us all. I think we would all think that we are egalitarian practitioners, that we treat everyone the same and we don't discriminate. And this argument is actually that is not enough, that we have to be proactively inclusive. We have to arm ourselves with cultural competence, cultural safety, and cultural humility, acknowledging upfront vulnerabilities of disadvantaged, minority, marginalized groups. And that then means that those patients who are considered within a marginalized group or minority group feel comfortable disclosing their identity and they have a positive experience. And I think it's something really that's a challenge for us as healthcare professionals to acknowledge and be proactive in this, rather than necessarily thinking, I'm very nice to everyone, that's enough. And really it came up again and again that actually that's not enough and that we have to be proactive about this. And so I'll finish with kind of 3 key points. So AYA cancer patients are not just in pediatrics, and they're not just in adult oncology or hematology services. They're in the emergency departments, they're in surgical departments. We are building our AYA cancer services, but we are developing them. We're in their infancy. We might hit adolescence soon. Internationally, it's a very key time in AYA cancer service development, with a lot of work around toxicity mitigation, expanding clinical trial access, and that piece about equity rather than equality. And I'll finish up, and I know we're going to do questions at the very end.
Great, thanks very much, Cheryl. That was excellent, fantastic overview. Our next speaker now that we'll move on with is Amy Nolan. Thanks very much for joining us. Amy Nolan is Director of Clinical Affairs at the Irish Cancer Society, leading their relationships with clinicians and healthcare professionals and institutional partnerships with hospitals and universities. She's a member of their executive leadership team, guiding their clinical services, and is their clinical spokesperson. She previously held the role of Head of Children, Adolescents and Young Adults and Interim Night Nursing Manager within the Irish Cancer Society. Amy regularly engages with the HSE, NCCP, third level higher education institutions, and international cancer bodies in the UK, Australia, and Canada. In 2022, she was admitted as a Fellow of the Royal College of Surgeons in Ireland in recognition of her career in oncology nursing and her commitment towards innovation, standards, education, and improving patient outcomes. Amy was previously lead cancer nurse at St. James's Hospital and has a well-established track record in innovative supports, campaigns, and national education programs to benefit both patients and staff. And we're delighted to have her speak with us today also. Thanks very much, Amy.
Thank you. And thanks so much for having me here today. I'm really delighted to be able to speak with everybody and to speak to the Rebel County in particular. It's really exciting. So I'm just going to give a little overview of our children, adolescent and young adult supports. And if I could just work out, Katerina, we had this worked out earlier. Sorry. So just who is on our team? We have myself, there's Claire McCall, who's our Kaya nurse coordinator. Roisin is our music therapist, and we've recently been lucky enough to have some administrative support as well, which is really exciting. So, second now, there we go. Thank you. Oh, sorry guys, this is just... Oh, and can you see the slides there? No?
No, Amy, the slides have come off there. It was working 2 seconds ago.
Okay, sorry, apologies. Just 1 second, and I'll hopefully be able to get this back on track. Now, are we back? No?
No, you're not sharing your screen at the
Sorry.
moment.
Okay.
Yeah, it's back there. We can just see
Okay,
it.
thank you.
And you haven't started the slideshow on it yet.
Okay. Okay. Right, thank you.
It's coming up actually there in presenter mode, Amy. It might even be
Okay.
handier just for you to you click on that.
Yeah.
Yeah, that's perfect
Okay.
now.
Sorry. Thank you. That's brilliant. So yeah, so we serve the Kaya community, which is 0 to 24, and we're going to go through some of our activities. And Sherelle described the numbers of patients. So there's usually 200 children between the ages of 0 to 16 diagnosed with cancer every year. And the typical duration of that treatment can be between 1 and 3 years. And as Sherelle mentioned, the survival rate is really good, and particularly for the AYA group, which is about 180 adolescents and young adults are diagnosed with cancer every year. So that would be your 16 to 24-year-olds. And Sherelle mentioned there that the survival rate is up to 90%, which is really fantastic. So this is just an example of a boy that we have cared for and provided some of our services to. This is Caden. He is 8, receiving his treatment in Crumlin, which is a 3-year program, and his family have availed so far of our Kaya nursing support. They have availed of our Children's Cancer Fund, which is €3,000 for any child who's diagnosed with cancer under the age of 18, and peer support also. So to be able to discuss and chat with somebody who's been through cancer diagnosis and the impact for their family with somebody else is really valuable. They've also availed of our creative arts therapy, which I'll tell you a little bit more about, and our Barrettstown camps. They're kind of like poster child for all of the services and supports that we have to offer in the Irish Cancer Society for this group. This is Claire McCall, and I know Claire, I think, is on the call. So Claire joined us in September as our Kaya cancer nurse. Claire has over a lot of years of experience in St. John's Ward in Crumlin, where every patient who has cancer under the age of 16 will be admitted at some point. And Claire has experience in a number of different childhood cancers. So to have her there one day a week and on a different day to meet patients and families and be able to signpost, direct towards our supports, direct towards a number of other cancer charity supports is really valuable. So she's constantly raising the awareness and providing information and support to families at a really difficult time in the diagnosis. Claire also plans to link closer with adult services. So if you receive a call from Claire in the coming weeks or months, Claire's been in touch with the Daffodil Centres and the clinical nurse specialists in Tala and beyond, just to try and provide that support to the AYA group in particular there. So for your 16 to 24-year-olds who maybe are not treated in Galway, Cork or St. James's or CHI, we're really aware that there is a group of patients there that require that support. We have a volunteer driving service, and that was launched for Dublin, Kildare, Meath and Wicklow. We have trained volunteers that are, transport children and a parent or a guardian to their appointments in Crumlin or St. Luke's. We also have volunteer driving service for adults. So for the 16 to 24-year-olds that are attending adult hospitals, that this service is available for them as well. And it really is a vital service for those children and young adults. The cost of car parking, as many of you know, can be up to €300 a month, which is hugely expensive. And in a time where there's a cost of living crisis, it really does have a massive impact on families. The Children's Fund, which I mentioned earlier, so it is a once-off payment and it's not means tested, which is really important to families. So this payment is €3,000 for any child who's diagnosed with cancer under the age of 18. And in 2022, 220 families availed of that grant, and last year 179 families availed of the grant. So if you are speaking with anybody who has a child under the age of 18, it's just really important to let them know that this is available to them. Some families don't want to avail of the grant. They feel, oh, there's other people who need it more, but it's really important to let them know that it is available, and it actually is really useful. You spoke with the mother there recently, and she said even just the buying of food, coffee, takeaways for their kids while they're admitted in hospital. She said the cost of a week in hospital can add up to about €500. So you can see how the costs really rack up. Sherelle mentioned earlier about fertility preservation, and we fund and work with the Marion Fertility Clinic. And over the last 3 years, we've worked with them and funded fertility preservation. So as you all know, chemotherapy can seriously impact the cancer patient and their fertility, and infertility then can become a second loss for those who do survive cancer. So we offer fertility preservation to adolescents under 18 years of age who are about to undergo cancer treatment, but fertility is likely to be impacted. And then also female survivors of childhood cancer from the ages of 18 to 27. That had been up to the age of 25, and we were able to extend that up to the age of 27, which has been really, it's been a great hope for adolescents in that age group when they've kind of come out of their treatment, and this is a huge issue and they're thinking about it. Children will also, as Sherelle mentioned, will benefit from groundbreaking fertility preservation methods such as the testicular cryopreservation and ovarian cryopreservation. So we're really hoping that there will be further progress in that in 2024. In 2023, 18 males attended for fertility assessment and preservation, 11 females attended for pre-treatment fertility preservation, and 17 females attended in survivorship for post-treatment fertility assessment. And last year we had an education day in Marion Fertility to try and just spread the word about this this support and this offering for this group of patients. And we also held a webinar, and if anybody would like to receive the link to that webinar, we can forward that in future. But definitely the referral rate improved and increased following those the study day and the webinar, which is brilliant. And what we find is that a lot of the young adults tend to talk to each other, and so referrals even that way comes to us, which is brilliant. We work very closely as well with Barrettstown, and many of you may know Barrettstown, may have volunteered in Barrettstown. It's a really lovely area down in County Kildare where there's fantastic work done with both children and young adults in therapeutic recreation, and they just come back feeling the magic of Barrettstown and the support around them. So it's really lovely time for families down there. Last year we had 3 family camps and 3 young adult camps, and they're really tailored for the young people with cancer. We had welcome packs and support packs, and some of our practical and financial solutions team were on site just for parents. When there was like a family camp, they would provide advice and support around navigating for some of the financial difficulties in having a cancer diagnosis, and also they were there for the young adult program as well. And they're both 2 very individual types of camps or programs. In 2023, we had 7 residential camps. So we had family camps in spring, summer, and autumn. And so there were 76 families that availed of those camps. And it's just brilliant for them to be able to meet people like themselves who are going through similar journeys, to use a phrase I don't tend to like to use, but it's just nice for them to be able to talk to each other, and for siblings as well, a family. So 344 individuals were served there. And then in the young adult program, we held that again in spring and summer and autumn, and there were 39 individuals in that. The young adult program is very different. It's for 18 to 25-year-olds, and we worked closely with Barrettstown in theming the program so that we're kind of learn life skills like cooking and financial kind of awareness about credit cards and or traveling and TripAdvisor kind of stuff. So it was built for them, and there was elements of coaching as well. So it worked really well for the young adults. They really enjoyed it, and in between that, obviously, have really exciting activities to do. We also held a family bereavement camp, and this was for families who had been bereaved by a parent. So this was a new pilot program that we held last year, and it worked. It was 15 families attended it, and it was a phenomenal, absolutely phenomenal camp, and great support to those families. So we are hoping that might be something we can do again this year. This is really important. So for any of you that are meeting young people or families with cancer, the dates that we have outlined for 2024 with Barrettstown. So we're going to have a combined family camp, will be on its own, but we'll also have a young adult program running on site at the same time. So the 26th to the 28th of April, and the 20th to the 22nd of September. What we're finding and what we seem to understand is that when patient is diagnosed initially, it's not the time for attending camps or that kind of thing. So it tends to be down the line a bit. And I think if you are somebody who's meeting people that are kind of a little bit down the road in their treatment or into survivorship, that these camps can be really, really beneficial. So it'd be great if you could take note of those dates, and we can also send them on to you again. But that's what we're looking forward to. No point in just listening to me about this. We have a short video here with a few young people who have availed of the young adult camp, and invite you to listen to that.
The young adult program is great because you're meeting kind of people who've been in the same situation, and in camp you're mixed with a lot of different medical backgrounds, if you will, whereas on the YA camp everyone's had cancer. So it's very similar experiences, and you can kind of share in that sort of, and it's, making friends like hopefully, you're going to stay in contact with, or potentially just see at the next way camp if you turn up. Like, I've done 3 and I've seen similar people and I've seen new people, or I've seen people kind of re-emerge from my past in having gone through cancer as well, which is really nice to catch up and stuff as well. So yeah, I really like it for kind of the social aspect.
When you go to the regular camps as a kid, everyone's actually playing, enjoying themselves, and not really thinking. But now when you come back as a young adult, it's nice because people are a little bit more on the formulated kind of opinions. It's nice to see. It's nice to hear stories from outlooks from people from illness to just life in general. It's more like food for thought in the young adults camp. Anything else I have to say like it is greatly appreciated. It's like I've never done like this before.
Online, it's like just a couple of things and all that sort of stuff. It really does. Like when I was younger, I used to be one of those kids who would bed every day and just like talk to a tree, that sort of stuff. But when I was, I don't even know what it was, but it just like shattered my confidence, and I couldn't leave the house, and I couldn't talk to anybody. So I understood so much about it. I just like came here and it just like switched in my head, and I just went straight back and I was talking to everybody, and I've not felt like anxious or homesick or upset for like even 1 second. The second that I saw like just relax, and I don't have to guard myself or worry about anything. It's also like a good place to just forget about everything. It doesn't matter what's going on. Well, relatively doesn't matter what's going on with your health. You can come here and you just don't have to think about it. And I also think that like talking really helps.
So it's great. I always think it's great to hear from people who've actually availed of the service. Another area that we're really excited about is our creative arts therapy. And this is for children, adolescents and young adults, but also for their siblings. So as we all know, there's a huge impact to siblings as well that if a child has been diagnosed with cancer. So our creative arts therapy is providing music, art, drama and dance movement therapies tailored specifically towards the Kaya group, and it just provides social, emotional, physical, and it's really developmentally appropriate therapy. It aligns with the recent psycho-oncology model of care in that it's within the community, and we've identified therapists nationwide who will provide support locally, so either in the patient's home, and what we have had is therapists who have worked with both the patient and siblings, just even around their relationship and how that works. Another quick short video here from Roisin Hayes, our music therapist, who has done a huge amount in this area.
So creative arts therapy, it has different mediums. So there's music therapy, there's art therapy, dance and movement therapy, expressive art therapy, and art therapy. So it's across different mediums. But the real function or the benefit for young adults is that it's a non-verbal form of communication. So young adults or teenagers might find it hard to communicate about different things. And through the other mediums, through the creative mediums, we can explore that in a professional way and support it accordingly. A lot of young people, for example, listen to music every day. They might listen to things that might be more sad on a day that they might be feeling sad, or angry music to express some anger, things like that. And as a qualified professional, I can use that as a medium to kind of talk to them, or maybe do some songwriting about how they might be feeling. And then similar to art therapy, it might be looking at expressing through art, making, and how does that feel? What's happening in the art? How do they feel about what's happened to them? And what they're going through. But also we can work with function, we can look at movement, we can look at speech and communication, all through a fun activity. So it's a little bit more relatable than the medicalized model. identity. They might bring a suggestion of a piece of music that might reflect how they are, or something that they like, or something that might be important to them. And even the act of sharing within a group can be really beneficial. It can offer another sense of identity for the person, a sense of purpose within a group, and the fact that others are listening to their song. So they don't have to listen to how they are and all their feelings and everything, but actually it can be done through a song. That can also be done through an instrument. So playing an instrument, even the way they play or the instrument they choose, and how they can play in relation to other people. Are they copying? Are they reflecting? Are they only playing by themselves and finding it hard to interact with others within a group? That can offer a lot of suggestions and a lot of conversation about what's hard for them. Do you find social interaction challenging, or are you relating to certain people within the group more than others? And the key there is the non-verbal communication. We don't have to use the verbal if we don't need to, or if it's not beneficial in any way, and it's less intrusive potentially than the verbal communication there.
So I think you can see there how beneficial those kind of therapies are, and we've received a huge amount of referrals to creative arts therapies, and really delighted with that and the impact that it's making. We are also piloting a life coaching session, so that's 6 weeks online, one-to-one with a life coach who is trained in working with young people and support career education, adulthood milestones. That's again that we've had 5 or 6 people on that program so far, and really good feedback from that too. Our night nurses provide care to both children and adults, as you all know, but to the under 18s and actually up to the age of 24, we would say that there is unlimited number of nights available nationwide. So usually patients would receive potentially 10 nights to 14 nights of night nursing care. But when it comes to our children and adolescent young adults, we really try to offer unlimited nights when there's available night nurses. So in 2023, there were 29 children with malignancies that were cared for, and that was over 218 nights. So again, providing vital support for children and families so that those children can pass away in their own homes surrounded by their families, and the familiarity of that. We have worked on a lot of events, AYA events, education and information and research. So we provided funding to the second CAIA's conference there last September for CAIA patients, families and healthcare professionals. And we worked really closely with Sherelle and Peter McCarthy, Niamh O'Sullivan on our AYA Education Day, which was held in Galway this year. So we might make it to Cork next year. But that was really beneficial for all healthcare professionals with an interest in caring and working with AYAs in Ireland. We've partnered with UCD researchers just to assess the psychological toll of applying for financial entitlements following a CAIA cancer diagnosis as well. We work very closely with our advocacy team, and so elements like the report to the hidden cost of hospital car parking for families, where I just mentioned to you there that can be up to €300 a month. We've had webinars around accessing products, financial products, and the right to be forgotten. So that's really important legislation, and there's been a new code come out with the insurance companies now to look at that and to give more advantage to young people who have had a cancer diagnosis and who are up to 7 years clear of cancer. So that's really important. And we work on a pre-budget submission every prior to the budget in our asks there. So that's really important as well. So 2024 and beyond, we hope to develop our volunteer driving service. We are very close to completing AYA support and information booklet. I'm working with the AYA team in CHI and St. James's, which is brilliant. We're expanding our National Creative Arts Therapy program. So, I mean, just even listening to that video, you might have an idea of how a group session might work well in the area that you're working in, or a group of patients, and you can just come to us and let us know about that. We are really delighted to be able to say that we're funding the complementary therapy service in St. John's Ward in Crumlin, where both parents and patients can avail of the complementary therapy. We're delighted about that, and we're working towards funding a play specialist in St. Luke's and Rathgar, so that those patients who attend for radiotherapy can have, instead of maybe needing a general anaesthetic, that the play specialist may be able to work with them so that they'll be able to have their radiotherapy without that. So that's something we're working towards. And we continue to work on early detection, and I think Sherelle mentioned that in her presentation as well, particularly around the AYA group, where early detection sometimes can be an area that really needs to be looked at. We've met with the cross-party group in the Oireachtas, and Professor Owen Smith joined us in that around early detection and the importance of education as well. Campaigning continues with the car parking charges, and we continue to have our webinars and high impacting topics. And that is it. If anybody has any questions, I'd be delighted to take them, or any suggestions or ideas. Thank you. And sorry for the technical difficulties there.
Thanks very much, Amy. That's a really wonderful overview of the work that's been done at the Irish Cancer Society. I had a few questions coming through. First, a question for Sherelle. Sherelle, on the topic of disparities for AYA patients, some of the research that we've seen has on survivorships, on cancer survivors in this age group, show that things like breast cancer screening or cardiovascular screening, patients in the teenage years are more likely to have that follow-up done for them later if they were treated by a pediatric oncologist versus an adult oncologist, say with the same treatment, same diagnosis, and same age. And that's a worry for me as an adult trained cancer specialist. And I wonder, why do you think it is that the specialist, whether it's a childhood treating or an adult treating, will have differences in the follow-up for patients?
Because, and I say this from having worked in both sides, we are much busier in adults. We have a much higher volume, and our turnover of patients is much greater. The guidelines that would guide the long-term follow-up are written by a pediatric organization. And so I think they're not as to the fore in our minds. And I think it comes down to partly culture, in that our toxicities that we think about on treatment we're focusing on very much on the acute toxicities. The long-term toxicities are something we would all love to be able to have time to consider and spend time on. But we probably have 50 patients sitting outside in clinic. And accessing regular, for example, breast screening is a huge issue. So young women who've had radiation, for example, for Hodgkin's, should all fall within the high-risk breast group. And actually, there's now evidence that even if they haven't had radiation, that the use of anthracyclines and alkylating agents full stop is a reason to have kind of high-risk breast screening. But those services have not been developed within, say, the breast group. They would say they're not resourced to do that. And some of those are, in some ways it's easier to turn down or to explain to your colleague you're sitting beside that you can't do something than if someone who is an external person has referred someone into you. But I think ultimately the fact that the guidelines are written by a pediatric group are much more accessible, are much more to the fore in the pediatric mindset. I think that has a big influence.
Thank you. And Amy, a question regarding some of the camps and the follow-up that Irish Cancer Society offers. One of the challenges that we've seen is for patients who, say, have had successful treatment and maybe that's a 6-month block of treatment, and they haven't engaged with the support services during that time.
Mm.
And when they come to that last appointment where they hear their scan is clear or get some good news, they sometimes will want to just forget
Yeah.
about the disease and forget about the diagnosis. And the last thing they want to do is engage with these services. Whereas we know that they would benefit hugely. The cancer journey isn't over after
Mhm.
6 months. You know, it's with them for life, really. How do you face those challenges?
Yeah, and that's a really good point, Owen, because and we have these discussions regularly as well within our team. I think, and we talk about late effects clinics, or you know, maybe that's a good time to introduce some of these ideas of the camps or maybe the coaching programs. I think in some ways we're with the grant for under the age of 18s, you know, there is that area where we can go back to people and say, look, are you interested in joining something like this? But it's that, and again, it's that lost tribe piece, isn't it? So it's that group 18 to 24, 25-year-olds that you're trying to attract. And we use a lot of social media to try and share and let people know what's coming up and what's available. I think yeah, I mean, I think it is very dependent on our clinical nurse specialists as well and their relationship with their patients, because they will often treat those patients for that block of 6 months, as you know, but they will still have that connection with those patients, and those patients will still have their number, you know, that they can contact them. And so I think that probably is our best link. And I think with the national strategy and with the hub and spoke model, and particularly with those nurses in clinical nurse specialist roles, I think that's going to be key in that area as well. And our daffodil nurses as well, of course, are embedded into the clinical pathways and in 13 centres around the country. So they are often dealing with parents who come back or young people. So yeah, I think that's probably the best way.
Okay, is there any more questions coming from anybody want to ask a question or type in the chat? They're welcome to.
Just to say as well, Owen, we are going to have a Colour Dash fun run at the end of June in Cork. So if anybody is around and would like to join the Colour Dash fun run specifically to earn to fundraise for our Kaya group, it would be great to see you down there.
Oh yeah, absolutely.
Thanks.
We could send out the emails and get us involved.
Be great fun. Thank you.
One other question that I had for either of you would be, say for staff members who are speaking with patients and families with cancer, is there any support or collegiality in the cancer network for staff members to like learn more about how to address patients and families?
You might want to take that, Sherelle. Yeah.
Well, I guess we're very lucky in that I think it was about 2 years ago, Amy, we did the communication workshop with
Maria Cable.
Maria Cable, who is a Northern Irish essentially nurse consultant who has a lot of expertise in this area, who speaks very eloquently on kind of the burden or the challenge for young staff members engaging with patients. Our last study that took place in Galway, we did a lot around communication. I would say that those are a resource. There's the also the fact that, you know, we're very happy to be contacted, and Niamh Sullivan is our assistant director of nursing, who's an incredible source of knowledge and information and kind of resources to the wider kind of national network. And again, soon we'll hopefully have a CNS in Cork who'll have access, and who, you know, a lot of our CNSs have become very much the key communicator within their networks. There are always kind of groups. So there's a group on a UK-based group called Don't Forget the Bubbles, and they do a lot on communicating with young people that are very accessible online, kind of short courses that are worth people joining.
Great. And a question from Professor Roisin Connolly is asking about clinical trials and coordination across the centres, Sherelle, as you kind of alluded to a bit earlier.
Yeah, so the ideal would be, you know, Owen, that say, for example, if we're opening a Ewing sarcoma trial, in CHI that utilizing the same structure that we're using with Altogether, where CHI is standing as the national site with data feeding in, without once we have that as kind of a proof of concept, that we will be able to open clinical trials based in one center. It doesn't always have to be CUH could be the key for one trial, and that the other sites could be almost satellite sites, so there isn't the same need for the massive infrastructure piece at each site, but that there is the possibility of opening in different sites. And then we also know within, say, the Cancer Trials Ireland network, that people are very good at referring patients onwards to a clinical trial where it's available. I think we'd follow that same pathway. And if we think about over time, there'll be a certain degree of centralization of these patients that will naturally feed into falling into a clinical trial network and portfolio.
Yeah, absolutely. I agree. If this age group has about 200 cancer diagnoses a year, about 40 or 50 of them are in this region of the country in Cork. So, we would want to feed into the network and, have all of our patients access those trials with you.
Yeah.
Okay, well,
Great.
thank you both for dialing on this afternoon, and that was really worthwhile. And we'd love to hear from you again in the future. And if you pass on any details about the fun run,
Great.
I'll share it with all of the group, and we can all be involved.
That's great. Thanks so much, Owen. Brilliant.
Great.
Thank you for having us.
Everyone.
Thank you. Bye-bye.
Bye-bye.